for 3.
Hi, we're going to talk about influenza and community immunity. The objectives for today are to understand the pathophysiology of influenza infection, to discuss methods of treatment and prevention, and to discuss how school-located influenza vaccine programs can help protect a community from flu. Influenza has been called the last great plague of mankind by some of the founding fathers of influenza research, and that's because every year flu plagues us. We have seasonal flu every year that causes epidemics. Every year, about 25 to 43% of children are infected with flu, and overall in the population, there's about 36,000 deaths from flu. There are many hospitalizations, many more illnesses, and there's a tremendous amount of cost in both direct and indirect cost related to flu. So to understand why flu plagues us like this, we have to understand a little bit about the viruses themselves. Flu belongs to a class of viruses called orthomyxoviruses, and these are RNA viruses, and they have a segmented genome. The little surface spikes on the virus are either hemagglutinin or neuraminidase, and there's 16 total hemagglutinin subtypes and 9 total neuraminidase subtypes. There's influenza A, B, and C strains. Influenza A is found in birds. There are wild birds and domesticated birds such as chicken, and all of the influenza A viruses in wild birds are represented. The 16 hemagglutinin and 9 neuraminidase subtypes are in these wild birds. There's also influenza A in pigs, but only a limited number of the hemagglutinin and neuraminidase types are there. And you also find influenza C in pigs. Horses can also get influenza A, but again, they only have a small number of hemagglutinin and neuraminidase types. Humans can get influenza A, but only the H1, H2, and H3 have been seen in humans, and the N1 and N2, and we also get influenza B and C. You also can see influenza sometimes in cats and in dogs, bats and in dogs. The reason that influenza is going to stay with us for a long time and isn't going to disappear even with prevention programs is because of that large reservoir of influenza A in the bird population. And these birds will then interact with domestic birds, and then they will interact closely with other mammals, particularly pigs, and then the pigs will transmit the viruses to humans. So this is how this can happen. And this may seem funny, but it has been shown that of the influenza pandemics so far, except for the most recent one, they have all originated in Southeast Asia, where out in the country, humans live very close to water birds, and they also have chickens, and they also have pigs that oftentimes sleep with them in their huts. And so you can see how all of this transmission can occur. So we talk about antigenic shift and antigenic drift with influenza viruses. And the antigenic shift, this interspecies transmission with reassortment, only occurs with influenza A. And that's when a new surface glycoprotein, either the H or the N, will be transmitted into humans. Antigenic drift is what happens every single year with flu, and that's little tiny point mutations that make the virus different enough that we have to change our vaccine, but there's not a major change in the surface proteins. Pandemics of influenza have been with us for as long as we know. The biggest pandemic of flu was the 1918 pandemic. I'm sure they occurred before that, but we don't really have records good enough to be able to document it. The 1918 pandemic flu killed about 6 million people worldwide. And that was when the H1N1 strain was introduced into the human population. And this strain circulated by itself until 1957, when it completely disappeared and the H2N2 was introduced into the human population. And this virus circulated by itself in humans until 1968, when it disappeared and the H3N2 virus appeared. In 1977, something different happened, because flu likes to do things that are different, and the H1N1 strain reappeared in humans with this pandemic, but the H3N2 didn't go away. And since that time, both strains have been circulating in humans. Again, in 2009, something different happened. We had the swine flu pandemic, as most of you probably know, but the H1N1 strain didn't go away. It just changed enough, because it was a swine virus, that we had a pandemic, and the H3N2 virus continued to co-circulate. So flu isn't just your average cold. It does cause an upper respiratory infection, and in children in particular, it causes a lot of ear infections, otitis media. And it is associated with a lot of bacterial pneumonia, and flu can also, in and of itself, cause a viral pneumonia, but it's not your average just cold virus. So the clinical symptoms of flu include the very abrupt onset of fever. That's all you get at first, is a very high fever, especially in children as high as 104 or 105. You also get muscle aches and a headache at that time, and this profound sense that you have to go to bed or you've been run over by a truck. Then within the next 24 hours, you get your cough, sore throat, and your runny nose. Almost as many as 20% of the young children who present with flu look like they might have bacterial sepsis, and many of them have febrile seizures. Parents will carry them into the offices and they look like little limp dish rags, because they just have the beginning signs of the flu. And the reason we have seasonal influenza is because of the temperature in our airways. The flu virus actually likes to grow better at temperatures below body temperature, at about 35 degrees. And so when you're breathing in cooler air, the virus can grow better in your upper airway. You can imagine when it's 100 degrees in Florida in the middle of the summer, the virus isn't going to grow very well in your nasal passage. This is what the normal respiratory epithelium looks like with a scanning electron micrograph. You see the ciliated cells and the goblet cells for mucus production. And this is what it looks like with a transmission electron micrograph. Again, you see the ciliated cells and the goblet cells. And this is what that looks like after 3 days of an influenza infection. Influenza completely wipes off all of those cells in the respiratory tract, and other respiratory viruses don't do this. This is what that same mucosa looks like 3 days after infection in the transmission electron micrograph. You see the cilia are gone, the whole cells are disrupted, and you also see little tracts that are leaky, are like little rivers for fluid to leak lower into the lungs. Now, 7 days after infection, things are starting to reorganize and look like they're getting a little better, and this is why it takes so long to get over the flu. This is still not normal after 7 days, and a lot of people will cough after the flu for 2 weeks until everything gets back to normal. Since influenza is also associated with a lot of ear infections in kids, this is what the eustachian tube looks like when it's normal. And this is what it looks like 4 days after a flu infection. So all of the fluid and bacteria that are in the upper airway and the throat can get into the middle ear in young children when they don't have their protective cells in the eustachian tube. So flu is associated with its clinical symptoms. You start off with symptoms, they quickly rise. At about day 3 or 4, you're going to get the worst part of the symptoms, and then you'll slowly get better. So at about a week, you're mostly over the flu. You may still cough and feel bad for another week or so. But the worst part is over after about a week. But there are children who will run high fevers, 103, 104, for 4 or 5 days with the flu. The pneumonia that happens with flu doesn't happen right at the beginning. If it's bacterial pneumonia, you'll have your flu symptoms, you'll start to get better, and then if you see the red line, then you start to get worse again. That's when you can have a bacterial infection on top of your flu infection. Pneumonia, ear infections, sinus infections. Those are the things that are most common, with pneumonia causing most of the mortality related to flu. You can also get a primary influenza pneumonia, and that's the black line, where you start off with symptoms and then they just progress. The mortality with influenza viral pneumonia is still very high, even in 2016 when we have great critical care in hospitals, because of the damage that the flu does. It bypasses the upper airway, gets right into the lungs, and then destroys the lungs. So the diagnosis of flu is made mostly on clinical symptoms. You have an influenza-like illness, and then we use other things to help us diagnose it, mostly rapid tests that can be done in pediatric offices, other doctors' offices, walk-in clinics, and emergency rooms. And it's usually a nasal swab put into the nose, and you can get the test results in about 10 minutes. You can also do other better tests that are called PCR tests, or polymerase chain reaction, and they usually do a panel of viruses, including flu. Those are usually done in hospitals or emergency rooms, and they take about 24 hours to get the results. Culture used to be the gold standard, but it's not used anymore with these other tests that are available. Risk factors for complications from influenza include being less than 5, but in particular being less than 2 years of age, being over 65 years of age. Pregnant women and women who have recently delivered children are at high risk for complications from flu, and anybody with a chronic medical condition such as asthma, diabetes, or heart disease. Treatment of flu is available, and it has both clinical, in that the patient gets better, and public health benefits in that you don't spread it as much if you get treated for the flu. So early treatment is beneficial because it shortens the duration of fever and illness, reduces the risk of complications and death, and shortens the duration of hospitalization. But it should be started within 48 hours of symptoms. However, if patients are in the hospital and very sick, sometimes it can be beneficial if started later. So treatment is strongly recommended for all hospitalized patients, for those with severe or complicated or progressive disease, and anyone in a high-risk group. But anybody can be treated for the flu. If you have the flu and you go and it's diagnosed and you want to be treated, you can be treated for the flu. It just needs to be started within 48 hours. There are good drug treatments for flu. There's some older ones that we don't use anymore. Most of you have probably heard of Tamiflu, which is given by mouth, and now we can use it all the way down to a baby 2 weeks of age. There's also Relenza, which is inhaled. It's kind of like an asthma inhaler, and that is approved for anyone over 7 years of age. And there's also several drugs that are in development right now, which you might hear about as time goes forward. So Louis Pasteur said when he was thinking about a disease, he never thought of finding a remedy for it, but instead a means of preventing it. And so we know with flu that prevention is really the key. It's not going away. It's going to be here. And there's always the possibility of a pandemic because of this broad reservoir in the bird population. So we have to prevent the flu. And flu vaccines are our best preventive tool. In 2008, the CDC recommended universal influenza vaccination. And that means that anybody over the age of 6 months, because babies under 6 months can't get flu shots, that anybody over 6 months of age, every year, regardless of risk factors, should be vaccinated against the flu. We have standard vaccines that contain nowadays 4 strains. They're called quadrivalent, and there's the flu shot. That's the flu shot. They contain the H1N1, the H3N2, and now, as of the last few years, 2 strains of B virus. It used to be that the B viruses didn't change that much, but in the last few years, again, because flu likes to do things that are unusual, the B strains started to diverge and were different enough that you had to have both in the vaccine to get protection. There's also the live attenuated vaccine that has the 4 strains called FluMist. And these vaccines are made weaker by temperature sensitivity and cold adaptation, and they can be used in anyone 2 years to 49 years of age if they don't have any asthma or any other medical problems. There's some newer vaccines. There's the high-dose inactivated, which is given to people over 65. There's more flu in it, so they get a better immune response. There's the intradermal one that is kind of like a little gun for people who are deathly afraid of needles. And then there's the cell culture-based, which is the FluCellVax, which is so the vaccine's not grown in eggs, so you don't have to worry about egg allergy and flu vaccines. And that one is approved now down to age 4. There's also something called the Flu Block, which doesn't have any virus in it at all. It just has the hemagglutinin, and the hemagglutinin is delivered by way of a vector. So everybody talks about the preservatives in vaccines, and the vaccines that we've talked about all come as single-dose vials. What that means is there's 1 dose of vaccine in the syringe, and that's it. And those vaccines don't have any preservative in them. You can purchase, although not many people use them anymore, multi-dose vials where there'll be about 10 doses in a vial, and because you have to enter the vial multiple times, they have to have a preservative. So they will contain that mercury-based preservative called thimerosal. So what's going to be the next pandemic? We know it's going to come at some point. It's probably going to be an H5N1, which has been circulating out there in birds, or an H7N9, which has been circulating. Both of these viruses have been shown to have sporadic bird-to-human transmission, usually in people that have contact with birds, people that work in aviaries or people who breed chickens, for instance. And it has been restricted to Asia. The virus is transmitted from the bird to the human, but we haven't been able to demonstrate, thankfully, that there's been any human-to-human transmission. But if these viruses ever mutate just enough so they can grow better in humans than they have up to this point, then we could have a pandemic begin. The scary part about these viruses, when they are transmitted to humans, is that the mortality is about 50% in the people that get these viruses. So to control flu, we're going to need better vaccines, which we're working on, and better vaccination strategies. And school programs are one of these strategies. Thomas Frieden, who's the director of the CDC, has coined the phrase, the only thing predictable about the flu is that it's unpredictable. And so we can see that that's what we're dealing with the flu. So the background for immunizing children is that we know that children are super spreaders of flu and that schools are virus exchange systems. It's very easy to spread the virus within a school. Kids also shed more virus and for longer periods of time. And Dr. Ira Longini, who is a professor here at the University of Florida, through computer modeling studies, has shown that if you immunize only 20% of the kids in a community, that has a greater impact on flu than immunizing 90% of the elderly in that same community. And if you can get 70% immunization rate in kids, you can protect an entire community from flu. So a real-life version of this was done in Japan. So after the 1957 pandemic in Japan, after they had a lot of mortality, they instituted a voluntary school program. And as you can see by the graph, in the black line, it's all-cause mortality. In the blue, it's deaths related to influenza with pneumonia, because that's the biggest cause of death, especially in adults. And as you can see, when they instituted the program, they both fell down. In 1977, when they made the program mandatory, they fell even lower. But then, when they made the program not mandatory anymore, deaths from all causes and deaths from pneumonia influenza began to rise. And when they stopped the program, then the levels were headed back to baseline levels, basically. So that, with all that in mind, that was really the beginning of our flu program in Alachua County. This is one of my favorite slides, not because of the little one getting his flu mist up at nose, because of the little guy in the background who's looking on at his buddy getting the immunization. So, Dr. Parker Small, who is really the mastermind of the control flu program, who's a professor emeritus and studied flu his entire career, went to the superintendent of schools and the Alachua County Health Department director, having heard the data that if we can immunize school children, we might be able to protect everyone from flu. And they went to the head of the Department of Pediatrics, Dr. Richard Bucciarelli, and being innovative leaders, Dr. Bucciarelli said he would give them seed money from the Children's Miracle Network to begin the flu program. So the program now consists of giving flu mist up until this year, and we'll talk about that in a minute, free of charge to all kids from Head Start through 12th grade in Alachua County schools, and that includes public, private, and charter schools. We encourage those children who aren't eligible for flu mist to get their flu shot in their medical home. We think that's a very important part of the program. And our goal, based on the data, is to immunize 70% of the students. The program is very labor intensive, begins in August right after kids go back to school, where the consent forms are sent out. We do a lot of community and school events promoting the program, and then we start doing the immunization clinics mid-September and finish by the end of October. We have a lot of support for the program in this community. We have many community partners. The pediatricians in our community are strongly supportive of the program, and parents really like the program because it's convenient, because it allows children without any insurance to get immunized, and because it's done at school. And most of them, once they begin participating, participate again. Pediatrician support has been crucial to the success of our program. Dr. Judy Banks said that she feels like it's the most successful intervention to help children's health in our community that she'd seen in her 30-year medical career. And Dr. Steve Landay said that he wholeheartedly supported the program and congratulated those that were responsible for trying to nobly protect the health of all our children. The University of Florida Department of Pediatrics and Emerging Pathogens Institute has been very, there we go, I'm gonna have to do that one over.
No worries. Are you going to just start from the beginning of the slide?
Yes.
Cool. Okay, you on in 5, 4, 3,
2. The University of Florida Department of Pediatrics and the Emerging Pathogens Institute have been very supportive of the program, as have many of our community partners. And even Alberta supports the program. Some of the hidden values of our program in particular are our nursing students. The program is part of the nursing student curriculum, and the nursing students immunize the students in the schools and also promote the program in the schools. And these nursing students are going to graduate and go out to other communities in the state and possibly the country, and they'll know the value of this type of program. We also have lots and lots of student volunteers. We have interns every year, and we have program coordinators and assistant program coordinators that help me who work with the program. The program has been recognized for its innovation and leadership. The program won the Best Program in the Nation award from the CDC and the American Medical Association. We were also recognized by the Institute of Medicine as a model for integrating primary care and public health. We received the Florida Commissioner of Education Award, and that was because they felt we were promoting education of students because they were in school and not out sick with the flu. And Dr. Small, the creator of the program, won the CDC Immunization Champion Award in 2012. In addition, we won another Immunization Excellence Award in 2013. So this places us and our program at the forefront of national efforts to develop innovative public health programs. And when we go to meetings and talk to people around the country, people are always saying that they want to model their program after our program. We want to do it like Alachua does it. We wish our program could be as good as your program. So in order to keep this program going, though, you have to have funding. And so the way we did this was we went to Choices, which is a fund that was not going to be working anymore, and we asked them for $1.5 million of the leftover money, and they did this for us. They put it into a trust, and we get up to $100,000 a year to help fund the infrastructure of the program. And we did this knowing that we would protect the county residents from flu, but that we could also use this program and the infrastructure of our program to immunize against other things if this happened. For instance, if we ever had an Ebola outbreak, we could use the program infrastructure to immunize. Or if we were immunizing against Zika virus, for instance, we could use the infrastructure of our program. So our program history, we had our pilot program in 2006-07 on the far left, and we have increased our immunization rates every year. In this past year, we actually immunized 14,700 students in the school. These are our program results, and we do best in the elementary schools. Our hardest group to immunize are the high schoolers, and of course middle schools in between. We were very happy with the last year that we got high school immunization rates up to about 30%. And in the middle and elementary schools, we're about 40 to 50%. If you take that together with what's done in the private pediatricians' offices, we're getting around 60% overall. Now, it's not at our 70% goal, but we continue to try to find ways to get to that 70% and improve our program. The surprising thing is that despite immunizing in the schools, and the green bars are the immunization in the schools, and the other bars are immunization in private pediatricians' offices. The yellow bars are combined flu mist in the offices and flu shot. And as you can see, over 4 seasons, the immunizations in the private practitioners' offices rose even as we were doing immunizations in the schools. So we think this is because there's greater knowledge and awareness of the need for flu vaccine in a community that has a school-based program. So how have we done? Have we done anything to decrease flu rates in the community, and how have we done in the schools? So as you can see from this slide, as immunization rates go up in the schools, school absenteeism goes down. So overall, we see a 10 to 20% decrease in both student and teacher absenteeism overall in the schools. And we know that getting the consent forms back is the key to getting good immunization rates. Our consent forms have a spot for the parent to check yes, they want to participate, or no, they don't want to participate. And just getting the consent forms returned will increase the immunization rate in a school. So if you can get 100% consent form return rate, you can get about a 60% immunization rate, which will get us even closer to our 70% goal. We looked at how we had impacted flu in our community, and this was published recently in a PLOS One article. And what we showed was that immunizing the students in the schools protects not only the students but other members of the community. In this slide, you'll see the red is Alachua County, the blue is what we call Region 3, which is the North Central Florida communities without Alachua County, and the green is the state of Florida. And this chart on the left is the 0 to 4-year-olds. And we didn't immunize these kids in the school, but they had less emergency room visits for influenza illness in Alachua County than in Region 3 in the state. The 5 to 17-year-olds, you see a similar picture, and you would expect this because these are the students that we're immunizing. So there's less flu in these students in Alachua County as compared to other parts of the state. When you look at the protection of all age groups, again, Alachua County has less flu. We didn't protect the seniors as well as we expected with our data, and we think this is because the large university population and the university students who work in the community are exposing some of our senior adults in the community. So we did expand to the University of Florida a couple years ago with a pilot program. Our program offered the flu mist, whereas the Student Health Center offers flu shots. So they had two choices. And we did the program in a variety of different locations to give them more opportunities to get vaccinated. Immunization rates on college campuses across the United States are very low, and we were right there with them with a 9.8% immunization rate in 13-14. And by offering flu mist and offering different venues, we actually increased the immunization rate in 14-15 up to 17.5%. And we are going to continue offering flu mist at the University of Florida. There are some important updates regarding flu mist, however. In June of this year, the ACIP met and decided that we would not be able to use flu mist in the United States for the 16-17 season. The good news is there was no safety concerns, but they had found lower than expected effectiveness of flu mist over the past couple of seasons. The issues primarily were with the H1N1 strain. And there were some differing results from the different studies, but the CDC and the Immunization Practices Council, the ACIP, decided that it was better not to use flu mist in the U.S. for this coming season. So there were 4 studies done, 2 in the United States, 1 in the United Kingdom, 1 in Finland, and neither U.S. study showed statistically significant effectiveness of flu mist against this H1N1 strain. 3 studies showed significant effectiveness against all strains when you lump the overall effectiveness of the vaccine somewhere between 46 and 58%. However, the 1 study from the CDC did not show effectiveness. And despite some disagreement among the members, the overall decision was to not recommend flu mist, even though 3 out of the 4 studies showed pretty good effectiveness overall. And in general, flu mist, which at one time had been better than the flu shot in these last few seasons, was less effective than the flu shot. So since we've been committed to protecting our community from flu, our program decided that even though flu mist would not be available, that we would do flu shots in the school with the same type of program that we've done all along with flu mist. Our school superintendent did ask that the pre-K and through 2nd grade students have a parent present because she felt like it would be important for them with fear of shots to have a parent present. We also are offering it to parents if they want to get it and to school staff if they want to get it, and we're making the school schedules a little different so that we can accommodate parents. But we are moving forward. So far this year, we've done the high schools and the middle schools, and we're working on finishing up the elementary schools. This is a picture of our program. Many of the members, our school nurses are integral to the program. Our nursing students are integral to the program. And Margaret Mead saying down there about a small group of people being able to have a great impact really rings true, and that's one of Dr. Small's favorite quotes relating to the program. We also have a website that you can learn more about the program on the website. Thank you. That's it.